Dr. Jayagopal,
Yeah, sure.
why don't you get the context going before the first case presentation? That will be good, isn't it?
Yeah. They'll just do an introduction and then I think we'll go ahead.
I thought she is going to start with the case itself.
No.
No, sir.
Okay, sorry.
It's very structured. She is very professional about it. Go ahead.
Sir, it's all your guidance actually.
Ma'am, we are good to go.
Thank you. So good evening, ladies and gentlemen. I'm Dr. Neha Jain, and I welcome you all on behalf of Emcure Pharmaceuticals to another exciting workshop of the Clot Buster series. Today, this is the 5th workshop of the series, and we are very delighted to have a very niche topic to discuss, which is the prosthetic valve thrombosis. We are very honored and delighted to have the stalwarts of the country to be discussing this topic with us. I take pride in welcoming all our faculty members today. I would first like to welcome and introduce our chairperson for the series. Our chairperson is Dr. P.B. Jayagopal sir. Sir is a senior interventional cardiologist and chairman of Lakshmi Hospital, Chittoor Road, Palakkad, Kerala. Sir is the president and scientific committee chair, Intervention Council, Kerala. He is also the associate editor of Indian Heart Journal and a life member of CSI and IMA. Sir is a principal investigator and national coordinator of Heart Failure Registry of Indian College of Cardiology. He is also the co-investigator in many ongoing national CSI registries like PRESCO, CSI COVID Heart Failure, and the COSTA study. And he is actively involved in the STEMI and heart failure research in the country. I now take the pleasure of introducing and welcoming our moderators for the event today. Our first moderator is Dr. K.U. Natarajan, sir. Dr. Natarajan is the senior interventional cardiologist and cardiac electrophysiologist, professor and head of Department of Cardiology at Amrita Institute of Medical Sciences, Kochi. Sir is a permanent training faculty for the pacemaker, defibrillator, cardiac resynchronization therapy teaching modules of Medtronic, St. Jude's, and Boston Scientific Companies. He is a proctor for implants of pacemaker, defibrillators, and proctor for cardiac electrophysiology procedures. He is also the examiner of DNB cardiology, final exams, and DM cardiology exams. He is the editorial board member and advisor for Indian Pacing and Electrophysiology Journal and a member of advisory board of Kerala Heart Journal. Sir was also the president of Interventional Cardiology Council of Kerala in the past. I now welcome and introduce our second moderator, Dr. K. Jayashankar, sir. Sir is the director and clinical lead cardiology and electrophysiology and director of Cath Lab services at Medway Heart Institute, Chennai. Sir was the director and mentor of cardiology and electrophysiology at MIOT Hospital, Chennai, and also the senior consultant cardiologist and electrophysiologist at Madras Medical Mission Hospital, Chennai. Sir's main area of interest lies in cardiac electrophysiology. He's also done a one-year-old fellowship in EP from Liverpool Heart and Chest Hospital, UK. Sir is a fellow of European Society of Cardiology, a life member of Cardiology Society of India, life member of Indian Heart Rhythm Society, and life member of Indian Medical Association. And he has publications in prestigious national and international journals. I now take the pleasure of welcoming and introducing our key speakers of the day. Our first speaker is Dr. Professor Guru Prasad Sogunuru, sir. Sir is a cardiologist and cardiac electrophysiologist at Sri Guru Heart Clinic in Chennai and Progress Specialty Clinic in Madipakkam, Chennai. Sir brings with himself over 17 years of experience in this field and has published over 30 articles in reputed journals. He has participated in various registries and clinical trials and investigator, and is also the member of prestigious bodies like IMA, Hope, Asia Network, and Indian Society of Cardiology. I now welcome and introduce our second speaker of the day. Our second speaker is Dr. Krishna Chandra Kagita. Sir is a consultant cardiologist and interventional cardiologist at Dr. Ramesh Cardiac and Multi-Speciality Hospital, Vijayawada, Andhra Pradesh. He was the associate specialist in TMH Jamshedpur. He has performed over 12,000 CAGs and 2,100 ETCAs. And he has also presented in many conferences. And he's got articles published in reputed journals like Indian International Journal of Science and Research. With this, I once again welcome and thank all our faculty members for being here with us today. And we look forward to an enriching session ahead. I would now request our chairman, Dr. Jayagopal sir, to give us a brief overview of the program.
Thank you, Neha. Good evening, everyone. I think it's indeed a pleasure to be part of this Clotbuster webinar this evening. I think the whole initiative was planned, and then, the whole concept came when a couple of years ago we wanted to really propagate the idea of many usefulness of the lytic therapy in current clinical practice. I think in the context of interventional cardiology, this is an area which is probably losing interest. And I thought when we had a discussion, this is one of the ways to really bring our attention back to this arena is basically by discussing on a few areas of the use of lytic therapies. So I think we started our program with the coronary arteries, where we had a couple of webinars on that, and then really wonderful cases, and in fact thought-provoking sessions and wonderful discussions we had. And then subsequently we actually had the session on pulmonary embolism and the current status. And then of course the last one was, I understand, very really widely attended, and then really appreciated by the entire audience. And I think that was on peripheral vascular disease, and both the arterial as well as the venous areas were really discussed. So I think we moved over, and then we wanted to also draw the attention into the area of valvular heart disease, and that's why today we have this discussion purely focusing on the use of lytic therapies in prosthetic valve problems. So with this, we have actually two really senior cardiologists here. Professor Natarajan has abundant experience in this area. In fact, he actually did his DM for one of the premier institutes, Chitra, where I know in fact, they have the original valve which was designed from Chitra. And then I'm sure he would have seen plenty of prosthetic valve related problems in his career. And then working in a place like Amrita, where they also would have done plenty of cases. So I thought he was probably the best person who could address this and to take this discussion forward. And also Dr. Jayashankar, who has been my close friend. He was earlier in Madras Medical Mission. I think a lot of contributions from that center, and now he has moved over to a new center. But his rich experience and also his expertise would definitely be of immense help here. So with this words of introduction, I would like to hand over the session to two moderators. Dr. Natarajan, I think you can take the proceedings forward, and then we'll have a discussion at the end of each session, followed by, and then I'll just give a brief overview of the current scenario, and then I think we can have a discussion towards the end, and that's the flow of the event this evening. Over to you, Dr. Natarajan.
Thank you, Dr. Jayagopal, for that nice overview and set the stage for the discussions on a very important topic. Fortunately, the problem is quite rare. Prosthetic valve thrombosis is a rare complication. However, large tertiary care centers which deal with a huge patient database on mechanical prosthetic valves as well as bioprosthetic valves, we do see cases. For instance, day before yesterday, we had a very dramatic case. We had a pregnant lady who had a precious pregnancy after many years of marriage, and she was started on low molecular heparin right from the first trimester. And she was in the 31st week of her gestation, and she presented with pulmonary edema. And on echocardiography, she had a huge thrombus burden on her mechanical mitral valve prosthesis. So I forgot to tell that she underwent mitral valve replacement surgery with the mechanical prosthetic valve for some rheumatic mitral valve disease many years in the past. So here is the pregnant lady, a precious pregnancy in the 31st week of gestation with a viable fetus in pulmonary edema with a massive thrombus burden. So there cannot be a better case scenario for actually discussing in this forum, though it is not part of the original agenda. So this patient, we had with all counseling and discussion, this patient had a simultaneous cesarean section and a redo mitral valve replacement done by my surgical colleague, Dr. Praveen Verma, less than 48 hours back. And both the child and the mother, fortunately, are doing well at this point in time. So that was a very dramatic case. So mechanical heart valves, as we all know, are prone for thrombosis, particularly if they are subtherapeutically anticoagulated, or if they have other issues like pregnancy, the case that I just alluded to, or some various reasons, whatever be the reasons. Usually it is subtherapeutic anticoagulation or some reasons where the patient did not take anticoagulation for reasons like pregnancy. We are also seeing more and more cases of bioprosthetic valves, which are also prone for thrombosis, especially in the TAVR era. I won't go into the details right now. We will wait for those cases. So I look forward. And surgery and thrombolytic therapy are most competing therapies in this arena. More symptomatic patients, class 3, class 4, and larger thrombotic burdens make a case for surgery. Less symptomatic people with less thrombotic burden, I'm sure we will go through such cases in the case scenarios that are going to follow. They are the cases where there is a role for anticoagulation with heparin, followed by thrombolytic therapy. And there are various regimens for thrombolytic therapy about which we shall discuss in the course of the sessions. Over to Dr. Jaishankar for your comments before we start the cases.
Good evening, respected Professor K.U. Natarajan, Dr. Jay Gopal sir, and my colleague Guru and Dr. Gita. I think it's indeed a very stressful situation for the treating cardiologist as well, not only to the family and the patient. We are at odds all the time, trying to figure out what is the best possible therapy or the best possible way forward for such patients. As you rightly pointed out, you had a precious pregnancy 48 hours ago and how you handled it. So I'm sure you have gone through quite a lot of stress because all ends well that ends well, goes well that ends well. Having said that, when we have a large thrombus and patient is in florid pulmonary edema, these patients also surgical intervention is also not a very great option for them because they are really sick. That's when we probably buy some time. And I'm sure during the course of the discussion, we'll have the various thrombolytic regimens which are available now. We have ultra short acting, as we call, to buy time. And sometimes we are even successful in lysing large thrombi without having to go through the risk of surgery. Having said that, I think I'd be happy to hear what my close friend and colleague, Dr. Guru, has to say. I think without wasting much time, we'll ask him to present the first case. So over to you, Guru.
Thank you, sir. Good evening to all of you. Respected Chairperson Jay Gopal sir and my senior Natarajan sir, Jaishankar sir, and co-speaker. And thank you, Emcure, for this opportunity. My case is a simple 2 minutes case because just a couple of years ago, just before COVID, one last year and one 2021 January 30th, I think this patient, and just a couple of months before, I present two cases. First, I could not get the details, but let me explain. The first 2 months before this patient, that patient was in the PM security person. So one of my friend's brother, he had some issues post valve replacement, and he flew over to Chennai, and it was a stuck valve classically. Because I was going through the updates on stuck prosthetic or prosthetic valve thrombosis, lytic therapies. So that's in that case, I tried Tenect place after reviewing a small meta-analysis. And because earlier he had GI plaque, and so that I thought it's just a fresh, simple bolus. And Tenect place, he responded only partially. Just a couple of months later, this lady landed up. So one of this 57-year-old lady is a mother of one of the medical intern. So 57 years, she underwent mechanical mitral valve prosthesis for rheumatic heart disease. So Medtronic Hall bileaflet in 2018. And she has been on acetylene. So I just want to emphasize that both patients were, my first patient and this patient, look at the INR. it's about to. So this is to say that, so normal INRs cannot immune 100%, 100% for prosthetic valve complications, especially PVTs, that is prosthetic valve thrombosis. So this lady went to swims in Tirupati, and they just came to Chennai. Just 1 week, she had the symptoms of class 2 to 3 in between. Initially to class 3 and then 2 few days later, and of 1 week duration. And ECG, clinically she looks okay, but because that exertional dyspnea was sudden, and she went to SWIMS hospital, and definitely it was enhanced gradients in the echo, and ECG was slightly tachycardia, though it was atrial fibrillation. And prosthetic valve gradients were enhanced in transthoracic echo with the mean 18, but peak is definitely, because earlier echo reports were reasonably okay. This is definitely sudden elevation of both transmicrotrachal gradients and no significant valvular or paravalvular regurgitations and reasonable biventricular function. So this was the fluoroscopic image, and you can see definitely one valve is stuck. And I did the transesophageal echo, though echocardiography, I could not get the image. I think even I called the opinion of my senior colleague Jayshankar sir, and there was something small clot like. Definitely it was not canus, maybe around 0.6 to 0.7 centimeters in area. And so because of earlier, though there was evidence that tenecteplase can be used in stuck valve or prosthetic valve thrombosis. So we all know that, all the agents, starting from streptokinase, though urokinase is less recommended or less evidence, tissue plasminogen activator. And of course, we have even papers and small meta-analysis of even this tenecteplase uses. So I went on for the good old treatment regimen. So bolus of 2.5 lakh streptokinase and 1 lakh unit IV infusion for 24 hours, monitoring every 4th hourly, transthoracic echo-wise, the gradients. And so whenever the gradients started coming down, I used to check the fluoro. And this is the fluoroscopy after 22 hours average. So definitely this is for me it's 100% success, and simple streptokinase has almost pulled it. But what I want to discuss with in this expert forum that because we all know if you stop the anticoagulation regimen or something by any chance, or during other sick, like other illness, comorbid illnesses which are really sick and significant, like trauma, coma, CVA, definitely there may be heard, or we don't know how they use anticoagulation therapy. There is a chance, but these two patients are very healthy patients and on reasonable INR levels, but still presented with stuck valve. And this is just 2 case scenarios where tenecteplase gave partial result. That patient also improved, but partially only. And this patient almost, because it's a short, window time is short, fresh patient, clear-cut history, and transesophageal wise, it was not canus. It's a fresh, looked like fresh clot, hemodynamically stable, though it's a class 2 to 3 symptoms. She did respond well. So even on good therapeutic INRs, still prosthetic valve thrombosis can happen. So maybe some, maybe internal or intrinsic genetic or coagulation defects, or some dehydration, or some, young patients, some other like pills, they may increase, coagulation profiles, that they may predispose thrombotic profile, or some infections. We have seen, COVID affecting patients. It can produce both bleeding versus clotting, both spectrum. We have seen COVID with varied and protean manifestation. So a lot of this is just the updates on pathophysiology, how can develop, and these are the guidelines, updated, latest. So simply just, right-sided or left-sided, mechanical versus tissue, and whether it is obstructive versus non-obstructive, and then the clot size. I think Natarajan sir has already presented. I think he took everything off from our, he took every word. So it's a beautiful case scenario, the beautiful summary of when to intervene medically, surgically, and when to thrombolize. So summary, this is the summary. If patient has significant symptoms with hemodynamic instability, straight surgery. And if okay, so 2 to 3 symptoms are class 1 to 3 or class 1 to 2 with less than 1 centimeter diameter or 0.8 centimeter square. So class 2 evidence for definitely thrombolytic therapy. So the question is on therapeutic INR. So the incidence of struck valves or prosthetic valve thrombosis, best strategy in our experience, though we have literature. So the guidelines, ACC, AHA, ESC, and American College of Chest Physician, all guidelines, they say, yes, definitely tissue plasminogen activator can be used, and streptokinase, though urokinase is the last. And of late, even the tenecteplase place, though it is used in some of the studies and trials. So I think, since my specialty post-graduation, I've seen maybe a dozen cases during my DM to till date. So most of them, I think a couple of cases went, one was mortality, one went for redo and surgical intervention. And most of them, at least more than 50% of them, they responded to streptokinase. And in my one case, tenecteplase did not do good. So I just want to hear the experiences from the experts. So this is the evidence, class 2A for fibrinolytic therapy, when it is indicated, reasonably stable patient, class 1 to 2, and clot less than 1 centimeter in size. And if it is, see that you have plus minus, the risk of thrombolysis is not small. It is 17.5% that it can embolize or it can produce bleeding. So we have to weigh, number one, and the contraindications of surgery also, if a sick patient. So that's very important. Morbidly obese or unfit or contraindicated for surgery, we have to think of lytic therapy only. And so every important points that matter when we choose lytic versus surgery is the fragility index, the risks of redo surgery or surgical intervention, versus the symptom status, hemodynamic stability, and the basic substrate, what it is. So because pannus, infective endocarditis, vegetation, mobile thrombus, or fresh thrombus, prosthetic valve adhesions itself. So this is the etiology. If we know that clearly it is a thrombus, small thrombus, reasonable hemodynamics and not very advanced symptoms, yes, we can go ahead with thrombolytic therapy. Thank you very much.
Yeah, Guru, do you remember what would have been the size of the thrombus on T?
Sir, we did, sir. If you remember,
size of the thrombus.
Size of the thrombus, it was around 8 millimeter in diameter and 6 millimeter. 8 bars. 8 is the length and 6 is the width. That lady, one lady, the doctor's mother. Yeah, it was in Mion. Yes.
It didn't respond, you said, isn't it?
It did respond very well. Within 24 hours, she responded very well, sir.
In the same line, of course, I would like to take the opinion of Dr. KU and Jayagopal sir. I have had a middle-aged lady who had a thrombus, something like this, after about 6 or 7 years of surgery on, it's not adequate, close to 2 is the anticoagulation. INR, and she refused lytic therapy. She refused redo surgery, and believe me, I just went up on the warfarin, and the INR was kept between 3.5 to 4.5. Luckily, no bleed. And subsequently, with time, her symptoms improved over the next 1 to 2 months. Slightly irrational, but then do you think what would you have done if patient refuses redo surgery or not ready for lytic therapy?
So really not ready for lytic therapy.
No, heparin. It was oral anticoagulation which was up titrated.
So definitely, if it is like low risk patient, definitely they say, and unknown duration, low risk patient, even unstable patient, when unfractionated heparin.
She was quite symptomatic.
Sir.
She comes to me for follow-up. Even now, I keep the INR between 3 to 4 all the time now.
Sir.
What has been the gradients during follow-up?
If I remember correct, the gradients have come back to normal. The leaflet has started moving again. At the time when I probably diagnosed with struck12, the INR was upwards up to 2.1, if I'm not wrong. And the fluoroscopy revealed something like what Guru had just shown. And that time it was a St. Jude prosthesis, if I'm not wrong. And, the gradients were 30 on 20, if I'm not wrong, again. And with time, it has come down to acceptable, something like 12 on 6 or 12 on 5.
No, she's one of those lucky patients.
I'm really surprised, and it was very foolish to not to prevail upon her for one of the two.
These are some of the you can call them outliers, where things go terrifically right when they could have gone terribly wrong.
Wrong also. But a word of caution over here regarding the INR. I think it has to be from a standardized lab. That's very important.
Yeah, that was in SWIMS.
Many times
our patient
we get carried away by the INRs done everywhere. Wherever, and then start titrating the drugs, or down titrating the drugs as well. So I think that's where I insist nowadays on INR from reliable labs.
Yes, sir. Yes.
Yeah, Dr. Jayashankar, I think the case scenario that you mentioned, I think Dr. Natarajan summed it up very well. The issue is sometimes we see this, someone with an INR less than 2.5 coming with this kind of problems. But I think I'm sure that it was because you had a fluoroscopy and imaging to confirm your diagnosis. But time and again, what we have seen is planus formation is something which can really increase the gradient. And sometimes when they go in for an AF with a fast ventricular rate, some of the gradient may be a little misleading. I think even in a stable case like Dr. Guru, what you had, maybe it's worthwhile to go for the MDCT and other modality imaging, which I'll touch upon in my presentation. Because that, the only thing is, as Dr. Natarajan said, if everything goes right for the patient, it's fine. But the risk of a lytic therapy with an INR of 2.2, I know if this lady gets an intracerebral bleed, then what happens? There's a big worry. So how do we go about it? I think Dr. Jayashankar's case, I have there are a couple of cases. What I have done, I just put them, escalated them, put them on additional heparin for 2-3 days, and then change the oral anticoagulants totally. Some of them, in fact, I don't know, some of them are on acetron, and you switch over to warfarin, they do well. It's just that.
I did precisely just that. I did just that. All the time we change the anticoagulant.
That's one thing which I have, somehow, again, when it works well, it works well. I really do not know. But that's been my thinking, like he also, Dr. Guru also showed a lot of factors apart from the INR, so the availability, the bioavailability, and the time in TTR ratio, whatever you call it, the time in the therapeutic range. When you check it, maybe 2.2, but then it may not be so during the trough time. So that's one of the, rightfully you went up on the dosage and then maybe add one antiplatelet. Some of them are not on antiplatelets. And time and again, we have seen the St. Jude's coming with this kind of problems. I would like to hear that comment from others as well.
Yeah. Yes, sir. Because when, because I quote this reference from Rahimtullah's lecture, which I attended personally. So he says, still the best valve is Star Edwards, still the best mechanical, more than 3 decades of experience, and because of its own thing. And these bileaflet metallic valves, definitely sometimes single leaflet or bileaflet. And we did come across maybe it's like, we stopped using Nokia, started using iPhones and Androids of latest, because, a denial towards the world. Maybe choice of the valve and the method. I don't, maybe whether surgical technique or choice of the valve, or maybe the sizing and follow-up matters. Everything is possible. But maybe, especially if there is INR is nearly 2. But of course, textbook guidelines say any metallic prosthesis is about 2.5, definitely. So even there is a window, maybe even the INR of 2 to 2.5, whether the thrombotic risk is high or other unknown coagulation profiles or coagulation factors or disorders play a role, is to be, maybe we need those aspects to investigate also whenever there is a facility.
With the permission of Dr. Jayagopal, I'd like to make a few points. One very important issue which Dr. Jayagopal very appropriately stressed was the differentiation between pannus and thrombosis. A lot of times patients come symptomatic, particularly with AF and fast ventricular rate, like what he mentioned. And you see there are a lot of very high gradients. And like what Dr. Guru said, it's good to go back to the old records and look at the gradients. If in sinus rhythm or at lower rates in atrial fibrillation, already if the gradients are on the higher side, probably you should have a lower threshold to call it pannus rather than thrombosis. Thrombosis is usually an acute development, and the immediate echo done in the recent past is likely to show lower gradients. So somebody comes with new onset symptoms, the previous echo shows normal gradients, and now suddenly you see that the gradients are very high, and the fluoroscopy adds to your diagnosis. And as Dr. Jayagopal very appropriately pointed out, there is more and more relevance for CT imaging because there are imaging characteristic difference between pannus and thrombosis. So earlier echoes showing lower gradients plus minus CT to guide in imaging will help differentiate pannus versus thrombosis. A lot of occasions we are actually thrombolized patients thinking it is thrombus, when actually in reality it is pannus. And when the patient is sent for surgery, the surgeon says that it is all pannus. And Dr. Jayagopal briefly spoke about the Sri Chitra experience with large volumes of prosthetic valve thrombosis, where I did my DM training. Those were the days. Surgeons never used to accept these cases. Nowadays, more and more surgical experience has come in, and they have a lower threshold to accept these cases for redo surgery. Now, redo surgery, the surgeons are quite happy to offer surgery to these patients, especially when the patient is very sick or when the thrombus burden is very, very large, like the case that I just spoke about in the recent couple of days back in our own institution. So the difference between pannus and thrombus is very, very crucial. And one should also remember that thrombolytic therapy in patients with extensive thrombus burden can be a double-edged weapon. In a given case, you may have excellent results, things go well. But all of you will agree with your own personal experience that some of these large thrombus burdens in very sick patients, when you lyse them, they have severe risk of systemic thromboembolism, particularly stroke. At least I have lost a few patients because of massive strokes needing decompressive surgery. Patients were literally vegetables. They just survive a few years, then they perish. So that is why this shift in paradigm of late in the current guidelines that you showed in your last but one slide, that very sick patients, large thrombus burden, we should have a lower threshold to subject them to surgery.
It is class 1 recommendation, sir. It is ACCHA class 1 recommendation for surgery.
And like Dr. Jaishankar has very correctly mentioned, patients who are not very symptomatic, who have INR of only 2, who are not on antiplatelet should be started. And if the patient is already on antiplatelet and INR is only 2, aim for an INR of 3. If the patient is having INR of 3 and already on antiplatelet, like Dr. Jayagopal said, further escalate to safer limits like 3.5, etc., is there in the guidelines to follow.
And even the guidelines.
Well summed up. And I think the only thing is, I think everyone should realize the surgery class 1 indication is first generation valves. So I think it's very important to see what valve has been implanted in the given patient. So I think that's the first step that we need to do before we really think in terms of taking a decision what therapy to offer to the patient. So
even the guideline says all the metallic prostheses surgery, apart from therapeutic INR, aspirin is a must.
Correct.
Aspirin is unless there is a contraindication.
Correct. Absolutely right. Dr. Natarajan, can we move over for more?
We had a great discussion.
Thanks, Guru.
Thank you, sir. Thank you.
Well, as we move for the next one, small comment, sir. The good old teaching that we should do serial echoes every 2 hours, that helps differentiation of thrombus from venous.
Absolutely.
That's a point to remember all the time, that we just don't start the lysis and go somewhere else. Too early echo for the gradient is a must.
Absolutely.
Absolutely.
And also repeat fluoroscopy.
Yes, absolutely.
And Dr. Krishnan, would you like me to present your slides, or you will share the screen? Okay. We can directly start from the case. We can directly start from your case.
Okay. Good evening, sir. Very nice to meet you all. Myself, Dr. Krishnan Talta. Today we will present about prostate valve thrombosis and use of thrombolytics. So, a small introduction. You all know that the mechanical valves, biological valves, stented, stentless, and percutaneous valves. The incidence being 0.5 to 8% in left-sided valves. And in India, the risk is more with 6.1% in the first 6 months after replacement of the valve. And it is a serious complication of valve replacement associated with significant morbidity and mortality. And the incidence is higher in the mechanical valves compared to biological, and the right-sided valves are more involved, and the mitral valve is the more involved valve compared to IOT. And non-obstructive thrombi are more frequently observed than the obstructive thrombi. And the early post-operative period, interruption of anticoagulation therapy for non-cardiac surgery and pregnancy are particularly high-risk situations for patients with prostate heart valves. And diagnosis based on cinefluoroscopy and echocardiography. And suggestive features include reduction or absence of lifted mobility and elevated gradients and decreased effective orifice area and thrombus visualization. And TEA has an important diagnostic role, particularly in difficult cases, and to differentiate thrombi from pannus formation or strands. And high mortality was reported with urgent surgery in certain subsets of patients with prostate valve thrombosis compared with the thrombolytic therapy. And intravenous thrombolytic therapy for the valve thrombosis has been used as an alternative to surgical treatment, and currently making a leading role in the management of valve thrombosis. And thrombolytic agents of common thrombolytic agents used in previous studies showed a different outcome and a various degree of safety in the treatment. And treatment of left side valves is influenced by clinical status, thrombus size, and the presence of obstruction. Mobile or large thrombi more than 8 mm are usually treated surgically. And critical ill patients, NIH class 4 and obstructive thrombi and large non-obstructive thrombi are indications for surgery. And obstructive thrombi with a small thrombus and stable condition with NIH class 1 to 3 can be treated with either surgery or fibrinolysis. And non-obstructive thrombi with a small thrombus less than 5 mm can be treated by fibrinolytic therapy. And right-sided valve thrombosis, fibrinolysis has a good success rate. And this is a chart already discussed. And my case, 30-year male, non-diabetic and non-hypertensive, known case of CRHD. I underwent mitral valve replacement in 2019 with the St. Jude valve. And he presented with class 3 to 4 dyspnea in since 2 days. He stopped medication for 1 week to undergo some dental procedure. So the introduction of anticoagulant therapy for planned invasive procedures. So for minor procedures like dental cataract and skin incisions, in which blood loss is very low, it is recommended that anticoagulation is not interrupted. And the major surgeries requiring temporary interruption and therapeutic bridging with either unfractionated or low market heparin, aiming a INR of less than 1.5. And the fondaparinux should not be routinely used for bridging, but may have role in patients with history of heparin-induced thrombocytopenia. So on examination, his BP is 90/60 and the pulse is 86 and SpO2 88%, and temperature is normal. So in presence of fever, diagnostic blood culture should be performed to rule out infective endocarditis. His BMI is 28.71 and body surface area is 1.62. And on auscultation, there are no heart sounds, and particular attention being paid for muffling or disappearance of prostic sounds and the appearance of new regurgitation or obstructive movement. So there were bilateral systematic captations, and 2D echo showed thrombus attached to the anterior disc with decreased mobility on the LV side and non-mobile clot of 6 into 6 mm. And transesophageal echocardiography was not done as the patient was in cardiogenic shock and needs immediate treatment. So transthoracic echo has an essential part of diagnostic assessment by providing direct visualization of the thrombosis and process and measurement of transvalvular gradient. The standard complete examination should be performed with particular attention directed at transvalvular flow, gradient, and inspection of the process. So in this patient, the thrombosal bilifted mitral wall with mean gradient of 22 mmHg. And echocardiographic signs of obstructive prostate valve thrombosis. So reduced valve mobility, presence of thrombus, abnormal prostate transpostate flow, central prostate regurgitation, elevated transpostate gradients, and reduced effective area. So cinefluorography is an important part of diagnostic evaluation. To increase diagnostic accuracy, several procedures should be performed to visualize the lifted mobility optimally. So, however, this technique will not help in identifying non-obstructive thrombi or differentiating the penis from thrombus. So, hence, additional diagnostic procedures are required. So, the direct signs of prostate valve thrombosis include abnormal movement of the prostate, immobile hemidisc, incomplete or delayed opening or visualization of paraprostate thrombus. For mitral prostate, a mean gradient of 8 mmHg and effective surface area of less than 1.3 is indicative of prostate valve thrombosis. And for aortic prostate, criteria for thrombosis are a mean gradient of more than 45 mmHg and obstructive index of less than 0.25. And what are the limitations of transthoracic echo? It includes quality of the acoustic window, artifacts associated with the process and non-obstructive thrombi. And in conditions of low cardiac output, transvalvular gradients can be within the normal range despite the significant prostate valve obstruction, so known as silent Doppler prostate valve thrombosis. So hence in clinical suspicion remains, the investigation should be completed with transesophageal echo. So finally, one must underline the importance of role of transesophageal echo in guiding the therapeutic strategy. The International Protein Registry identified previous cerebrovascular event and a thrombus size of more than 8 mm as the major risk factor for complications of lytic therapy. And the thrombosis of bioprocess has a similar clinical presentation to that of mechanical one. So in case of obstruction, transthoracic echo will demonstrate abnormal transvalvular gradient and exceptionally the presence of thrombus. And transesophageal echo must have a greater sensitivity than transthoracic. So he was thrombolized with altiplase 10 mg, bolus followed by 90 mg over 90 minutes. And the patient was monitored for success or failure of hemodynamic improvement by serial transthoracic echo for every 6 hours and for any other complications. So 2D echo did not show any improvement in the gradients and thrombus size of 5 into 5 mm with class 2 to 3 symptoms. So he was again thrombolized with tenecteplase with slow infusion 40 mg over 24 hours. And after successful thrombolysis, heparin was given and followed with acetron for target INR. And aspirin was added 75 mg daily, and heparin and acetron were continued until PT-INR was in the range. And next day, 2D echo showed normalization of the gradients and thrombus not visualized. And he was titrated with acetron dose and added aspirin, and target INR to be maintained of 4. And counsel patient to take adequate precautions and discharge in stable condition. And what are the fibrinolytic treatment protocols? There are no actual consensus in the literature concerning a best fibrinolytic regimen. And a simple therapeutic strategy can be in patients with hemodynamic instability, rescue fibrinolysis with a short.
I'm sorry, Dr. Kagita, but can we just go to the case? Maybe we can discuss this, the protocols, if we towards the end of the case, because I think there is one more case you will be presenting. I would request we
second case.
Yeah, please. If there is any theoretical slides in between, maybe we can save that for the later part of the.
Sure.
And we can only in a flow.
60-year female, non-diabetic and hypertensive, came with class 3 dyspnea for 2 days, and she was underwent Emcure in 2005 with the ATS valve, that is bileaflet valve for 23 mm. Her BP is stable and her heart rate was 86 per minute and temperature is normal, and BM of 21 and body surface area of 1.3. And there were muffled heart sounds with bilateral crepitations and SpO2 of 94%. And 2D echo showed increased gradient across prosthetic metal wall with a peak gradient of 35 and mean gradient of 23, and moderate TR and TR gradient of 55 mmHg. And PTINR was within the range of 3.65, and she underwent a cinefluorography which revealed restricted movement of one of the leaflet of prosthetic clot. In the cinefluorography, we can see that only one leaflet is moving, that too in a restricted position. One leaflet is not at all moving.
We cannot see that. Maybe you need to share the, or you share your screen. Share the window so that wherever you click, only that part will appear. Or you can go where the video is being played and share that.
It's okay. I think you can go to the next slide. It's okay. Everything.
Yeah. Okay.
So she was done with the TE, and TE also showed a restrictive movement. And she was diagnosed to have pannus in the wall, and she was advised for redo Emcure. So that's all with the cases.
Thank you, Dr. Krishna, for those two very nice cases. One demonstrating the value of lytic therapy, and the other demonstrating the importance of recognizing pannus and not lyse the patient, but send the patient for redo surgery. And you also set the foundation for the next most interesting and awaited talk by Dr. Jayagopal. He will, I'm sure, touch upon the various thrombolytic regimens, and you very correctly said there is no consensus. It is more of experience-based recommendations rather than consensus. But there is some evidence now in the guidelines to prefer one particular agent over the other. So I look forward to Dr. Jayagopal's talk on characterization of high gradients, how to deal with obstruction, how the symptom status of the patient makes an impact on the way we treat, when to lyse, when to consider surgery, and if lysis, how to lyse the patient. So over to Dr. Jayagopal. Unless Dr. Neha, you want to add something before he talks?
No, sir. Just looking forward to Dr. Jayashankar's comments also on these two cases presented. Just a brief discussion over any aspects that he wishes to discuss, and then we'll go to Dr. Jayagopal's response.
Yeah, I think the point has been nicely reiterated again that we need to switch over the anticoagulant and also all the time add an antiplatelet if there is no compelling indication not to. And the various clinical scenarios, as Dr. Guru had pointed out, we should bear in mind all the time and just not jump and lyse the patients. Take the history and examine them properly. I think the points have been well brought out. I think we should move on.
Thank you, Dr. Dhanarajan. So hope my slides are visible.
Very much, very much.
Yes,
Yeah.
sir. Yes,
I
sir.
think we had two fantastic cases. Actually, one, I mean, both difficult scenarios and also an interesting case which was discussed by Dr. Natarajan. So my job today is just to give an overview. I may not be really thorough and complete in my talk here, but I think we'll set the ball rolling for some discussion also in between. So the mechanical valve thrombosis is very unusual, as was pointed out. But I mean, time and again we see this in our practice. And the major problem is that if you don't recognize this in time, this finally leads to a very high mortality, close to about 30%. And peak incidence usually occurs 1 to 2 years post-valve implantation. All of us know the difficulty of maintaining the INR in the right the therapeutic range, and also the kind of labs that we have, as was mentioned by Dr. Jayashankar. It's very difficult sometimes to keep a track on the patient and to have the desired INR range. Now, this you have actually seen earlier, very well discussed by Dr. Guru, because it's just not the INR that we need to really worry about. When you see a patient on an anticoagulant, all these things are very important. And these etiology one should not forget. So I think you must have a complete evaluation of the patient starting from the history, as was mentioned rightly by Dr. Jayashankar. Just not diagnose an increased gradient across the prosthetic valve and lies straight away. So it's important that you do a clinical assessment of this patient before you jump onto the therapy. Now, I think it's very important to understand that most of us, really called in when the patient predominantly present with an acute decompensated heart failure and they're in cardiogenic shock. And at that point of time, it's very important that you rule out a prosthetic valve thrombosis. As was rightly mentioned by Dr. Natarajan, the way to differentiate clinically, PANS is often going on for a while, whereas a prosthetic valve, a stuck valve, is often an emergency. And then time and again, you might see like the cases which was described, sometimes a non-obstructive the valve thrombosis, which is an incidental finding. And there, I think you should take every precaution before you decide on the final therapy. The partial obstruction, for example, obstruction of one leaflet sometimes can manifest, which has shown a couple of cases here with the abnormal dyspnea, or sometimes even sinister systemic embolization and the grave effects related to that. I think the more important thing is just before I think it has to be a systematic. I am always a slave of a systematic examination and also a meticulous workup. I think there is no denying that fact, and I'm sure Dr. Natarajan will also agree with me in that context. When you look at this patient, you have specifically looked for a muffling of the heart sounds. When you're not hearing the click, that's the first sign. And of course, when you have other clues like fever and things like that, endocarditis, which actually does not. And in endocarditis, in a prosthetic valve, they may present with an acute heart failure, but then by that time, they've been going on with some other symptoms for a long time. And the biological tests, which might all the inflammatory markers really wouldn't help you at that point of time, except in the scenario of COVID, where we have had some problems in the COVID pandemic also, where the patients on mechanical valves have come with thrombosis. So that's difficult. I think the crux of the problem is to identify this, and that's where imaging really comes in. So I think when we were all doing our training and in our early formative years, we only used to rely on two things. One was the moment in fact, even before an echo was done, we remember our days when we used to take this patient to the X-ray and just do a fluoro and see what is happening to and time and again, the first message that I want to convey to the audience is it's often the tilting disc, which is a culprit, as I'll show you from the literature, what we have at this point of time. So the imaging, prosthetic valve thrombosis, going by the guidelines, is I think very appropriately mentioned. Today, it's a class 1 indication, recommendation of diagnosis of an acute mechanical valve thrombosis is basically by doing an array of tests like the transthoracic echo, which is a basic thing, transesophageal, if the patient is not very sick, fluoroscopy one must not forget, and of course, what has really come into play is the multi-detector CT imaging, which I need to stress into, because this not only gives you an idea of this, also tells you the structure, the anatomy, for example, an aortic valve, the LV outflow, and all the structures and the presence and extent of thrombus. All these things can be really meticulously brought out by CT imaging. And we are also in a new era, which was briefly mentioned by Dr. Natarajan. We are now seeing post-TAVR, the bioprosthetic valve thrombosis. In fact, you look into any of the leading journals today, the emphasis is only on TAVR and structural interventions. Gone are the days where people give the entire focus of the journal onto the coronaries. So today, wherever you read, this is only that. And then the mention is about the CT in these patients, some of these patients who have a complete heart block, or some of these patients when they follow up, incidental finding of picking of a pannus or a little bit of a thrombus on a CT. So in the context of a bioprosthetic valve, 3D echo has really come into play, and the 4D CT imaging, because you need to really be very, very careful there, can be useful to rule out leaflet thrombosis. So I think this is really coming up in a big way in the era of structural interventions. So I think this is a picture which is familiar to every one of you. I don't think I need to dwell too much on this, but then what is often forgotten, what is available with us is mostly 3D echo. This is a wonderful non-invasive tool. You can really look at the wall whichever way you want. And large thrombus marking completely and obstructing one of the leaflets can be beautifully brought out by a 3D, which is an inexpensive, of course. I'm sure all the leading teaching centers have access to this modality, and this is really a wonderful way to go about. So when you have even before jumping onto TE, I think a transthoracic echo with 3D will give you sometimes a real clue as to the etiology. But I think what we were mentioning earlier, it is very important. That's why I thought I should bring in this slide here. How to differentiate a pannus from a thrombosis. The thrombus formation is the most common thing when you're in a mechanical thrombus, but then the chronology, if you look, is minimum 12 months. It can occur anytime. The relationship anticoagulation has got a very poor relationship. Whereas even a thrombus, I think the first step that you do is, when you have in doubt, repeat the INR twice. In fact, in my lab, it's a standard practice to get 2 INRs done with two different reagents to make sure that you are on the right track. And of course, you look at the areas where it's involved. Pannus is often a small mass, whereas in a thrombus, it's often a much larger mass. And it is mostly along the suture line, the centripetal growth, and the echo density. Also, this is supposed to be very specific, 100% specific for pannus. But what is more important is the cardiac CT, again, is a way to go about. That can really differentiate. And the impact on gradient mitral valve more than the aortic, and then impact on the disc motion also is very important in the thrombus. So I think these are few things which could really differentiate a thrombus from pannus, which is often the first step in the diagnosis. And I just wanted to spend some little extra time on this, because it's not just a cine fluoroscopy which is available anywhere. And when you can easily, ease of use, you can easily find out the function. In most of the cases, it's brought about by just a fluoroscopic image. But then I always find many cardiologists confused as to what view they should be looking for a cine fluoro. I'll come to that a little later. But then the cardiac CT, I think, though there is a worry about the radiation, but I think if you have the access to a cardiac CT, that's the best way to go about for really bringing out. And of course, people also talk about the CMR these days, good for aortic pathology, no radiation, and the myocardial characters in addition can also be brought out very well. Of course, people also would like to, sometimes these people, when they have a doubt about an infected endocarditis, they go to PET and things like that, which is beyond the scope of this discussion here. So we are really focusing on the valve thrombosis. So I think the fluoroscopy should not be forgotten. It should be one of the earliest steps to done. And like what was mentioned, the best view, in fact, many people feel that the RIO caudal and 30-degree caudal will be appropriate. Some people believe in a PE and also sometimes in a left lateral. But I think any view, whichever it is, you need to see the two leaflets separating. And then if you are not able to see that, I think that's a first clue to the diagnosis. So I think it's a time-tested one, when it's easily accessible, inexpensive, and should go about. So the importance of multi-detector CT, I think I need to again emphasize that accurate evaluation of the prosthetic valve structure and function. Thrombosis have a lower attenuation than the fibrotic pannus. You can easily differentiate. It can also characterize the etiology of prosthetic valve thrombosis, especially the newer ones, the bio prosthetic valves, and also particularly in the context of TAVR. And in several centers, it's become the test of choice after the initial echocardiography. I think that's a key change in the practice today in the context of prosthetic valve thrombosis. So how do we manage? I think the discussion has been mostly on that. It's either surgery or thrombolytic therapy. In some cases where you're now really not in an urgency, maybe you could anticoagulate, and like what was mentioned by Dr. Jaishankar, in some cases it really works, and I think you need to really choose your patients well. So what is the current status of thrombolytic therapy? I must confess that this is not a new modality of treatment. It's been there for the last 50 years, way back in 1971. Since then, thrombolytic therapy has emerged as an alternate for surgery. And rightly pointed out by Dr. Natarajan, many of the surgeons in earlier days were scared to touch these patients for a redo because they were very sick and they were always worried about the results. Fibrinolytic therapy restored normal valve function in about 64% in the earlier days. It carries a high risk of cerebral thrombosis. In fact, I remember the days. I just wanted to share my own experience. This is exactly 30 years back when this was the first 2 cases which we reported. Experience in thrombolytic therapy. In fact, these 2 cases, one was at the mitral position. It was a St. Jude valve, if I remember correct, and then AVR. This was actually in the abstract issue of the Indian Heart Journal. So this is 1992. This was published. So these were the surgeons were very reluctant those days, as you rightly pointed. They never wanted to touch this patient. So there were only few case reports which were recorded worldwide. And I remember there were about 8 cases from GB Pant, one of the centers in Delhi at that point of time, which was also presented in that CSI conference. In view of the critical condition, we actually did not give a bolus days. We started with 1 lakh units per hour, gave it for about 12 hours. And to our surprise, there was a dramatic improvement and the patient, both of them recovered. And I vividly remember the incidence of, the only worry was we had to really watch these patients. The only worry was the systemic embolization, which was close to about 18% those days. I remember the figures. I don't know. I heard Dr. Guru saying that it's somewhere between 16 or 18% these days. So, a lot of development has taken place since then. Thrombolytic therapy, actually, this is one of the publications, Circulation 2013, was where with a low dose of tissue plasminogen activator, this was tried out. And this low dose, low infusion of TPA with repeated doses as required was found to be an effective therapy. And the thrombolytic success rate was very good in these patients. And you can remember even in the group of patients which we discussed a little earlier. So this came as a paper where thrombolytic therapy should be considered first-line therapy in pregnant patients with prostatic valve thrombosis. So I think there's scope for some discussion here. So this was one of the things, and so much so, they also came out with the definition of what a successful lytic therapy was when there is a reduction in 75% of the thrombus largest diameter, but it's sometimes very difficult to, there is no objective way of doing it. Return of the gradient to normal range, that is perhaps the only thing which can easily be picked up, and partial hemodynamic success when there is a partial improvement in the valvular gradient. And rightfully pointed out, you need to keep on following up this patient with the transthoracic echo every 2 or 4 hours. So based on these things, the recommendation, this is the 2017 guidelines, came out with the guidelines that fibrinolysis was given a class 2 indication at that point of time. Urgent emergency valve replacement is recommended for obstructive thrombus critically ill patients without serious comorbidity, which was a class 1. Whereas class 2, and what was mentioned at those days was using a RTPA, a 10 milligram bolus and 90 milligram in 90 minutes. This was a recommended dosage with unfractionated or streptokinase. 15 lakh units in 60 minutes. We all started with the infusion of 1 lakh per units, but then the criteria came in where you could, just like your lytic therapy for coronary artery, it could also be given just like that over 60 minutes time. And then surgery should be considered for a very large, more than 10 millimeter thrombus, non-obstructive thrombus. And of course, then also there is a discussion of bias therapy, but then ever since then, we have seen a lot of other articles also coming. I think I just wanted to quote something here from our own literature. This is actually by the Madras Medical College, where Kadirvel and Dr. Justin Paul, their group. This is actually a fantastic paper. This came in Indian Heart Journal about 52 patients, where actually this was a comparative study between streptokinase, and till then streptokinase was the most favored drug in the Indian context because of the cost factor. So this was actually about 40 compared to about 12 patients, and most of them were very, very sick patients, as you would see. About 40 were in class 3 or class 4 symptoms. And again, look at that. St. Jude's at Sorin bileaflet had the largest percentage in both groups. And the echocardiogram features, again, a significant gradient across the valve. And they found that slow infusion of TNK was equally efficacious but more effective than SK in the management of mitral mechanical processes, 75% to 77.5%, and completely recovered from the thrombolytic therapy. And they came out with this suggestion that should be the first line treatment. And going to this paper further, it is also interesting to note that honestly, all of us thought that this is a drug which should be given only for a period of 24 hours. But then it's interesting to note the duration of thrombolytic therapy in this paper. When they looked at the success of this patient, the partial success, they knew that this was working. So they went on with a little bit of extended sort of a therapy, 30 hours, 36 hours, 42 hours, and up to 42 hours with SK, and also not with tenecteplase that much. It is mostly given for about 18 hours. And they found that the total lysis time, as you could see it from here, mean time for successful lysis was about little longer for the streptokinase, but little shorter for the tenecteplase. Of course, this is a very small number for comparison, but I think in the Indian context, this is a good paper to compare. And of course, what was very interesting is that the mortality percentage is very low, but a large percentage of the patient, 5 out of 40, that is exactly the figure I was quoting, had a stroke. So this is something which we need to be worried about, more so in the context of streptokinase. Unlike, tenecteplase, again, a very small number, there was hardly anything, but the minor bleeding were much more with tenecteplase. And I just came across a recent paper, this is in circulation in Journal of American College, again by Justin Paul, the same group, where they have efficacy of a new accelerated thrombolytic. They have called it as the accelerated Madras Medical College regimen, MMC regimen, which is for prostatic valve thrombosis. So tenecteplase was given as a 0.25 milligram IV bolus and followed by an infusion for about 0.25 milligram per kg infusion for about 12 hours. And they did it on 15 episodes, 39 first episodes, some in recurrence as well. And on the left-sided valves, at 12 hours, 80% had complete success. 5 patients had partial success, 6 had treatment failure. 1 patient had to undergo, that is all. 1 patient had to undergo a redo surgery. But 5 patients died of major adverse cardiac events like heart failure, 2 died of massive ischemic stroke, and 3 died of intracranial bleeding. And this, I personally feel this has been pretty much the experience that we also have had with the prostatic valve thrombosis lytic therapy. So I think I also have another young patient. In fact, very funny, this is a 42-year-old guy who came to me with a acute onset breathlessness in pulmonary edema. And he had a mitral valve replacement done 27 years back, but he was never on oral anticoagulant. He came from the Tamil Nadu district. He was not on, the adjacent district of, Tamil Nadu. And then he was never on anticoagulant. I was surprised. And then, so at that point of time, lysed him with streptokinase, did very well. The gradients came down. He was better. But then what happened? He was on an heparin infusion. 48 hours later, this guy had a sudden weakness of the left MCA territory. Then I knew that this patient had a bleed. But to my surprise, in the middle of the night, when I took him for a CT, he actually had an ischemic infarct. And this was one patient where I actually went ahead, took him to the cath lab, and then took a shot and found that the middle cerebral artery was blocked with a thrombus there, and then used an intraarterial tenecteplase, and the patient recovered and is doing well even today. So I think this is, anecdotal reports from here and there, but then this has been, the tenecteplase has been found to be useful, and this is one way of going for it. So the prostatic valve thrombosis intervention, class 1, for patients with a thrombosed left side valve who present with symptoms of valve obstruction, urgent initial treatment with either a slow infusion of lytic therapy or an emergency surgery is recommended. This is a class 1. There is no doubt about it. So the 2020 ACC-AHA guidelines, actually there are different guidelines as to which patient should go for a fibrinolysis, which was probably discussed a little earlier. When you don't have a surgical expertise available, that's the first important thing. When they have a high surgical risk, when there is no contraindication fibrinolysis, when it's the first episode of valve thrombosis, when they're very sick, class 2 or 3, of course, small clot, no LA thrombus, no other valve disease, and if thrombus is visualized. And finally, the patient choice is extremely important. Like what Dr. Jaishankar, if the patient refuses lysis, what can you do? You can't do anything about it. But then you must also understand that, like what Dr. Natarajan mentioned, if you have surgeon is willing to take up the patient and they're fairly competent and capable of coming out unscathed, then I think you can take up the patient for surgeries. But more so if there is a contraindication for fibrinolysis, like the pregnant lady, the precious child. So all these things are contraindications. So I think it's perfectly justified in that context to go ahead with lysis. So I think this is just an algorithm where obstructive thrombosis suspicion, you confirm it by either a fluoro or a transthoracic echo. If it's critically ill, yes. If the surgery is immediately available, well, you can go ahead. But if it's not available, don't wait for anything. Go ahead with the fibrinolysis. But if they are not critically ill, if they are recent inadequate coagulation, if it's yes, you can use unfractionated heparin and aspirin. And if there is a failure, then I think high risk for surgery, you can go for fibrinolysis. So that is the flow chart for how prosthetic valve thrombosis management. And when you have a non-obstructive thrombus, that is where the question comes in, when you really should be, I think this is a time when you need to really work up the patient well, do all modalities of investigations, and then even a CT at this point of time, optimize anticoagulation. And if there is a thromboembolism, very large thrombus, well, the patient has to go for surgery, or fibrillate the surgery is very high risk. If it's not so, you can optimize anticoagulation, follow up, and then go ahead. But if it's a large thrombus, and there is no thromboembolism, you can optimize the anticoagulants. You can look for if the thrombus is persistent, then at that point of time, you can consider surgery probably is the first choice. And only fibrinolysis comes in if the surgery risks are pretty high. So I think this is the way to go about. I think I would like to end my talk by just briefly touching on the bioprosthetic thrombosis, where today it is divided into all the various fields, just like your stent thrombosis, acute, subacute, late, and very late. Of course, the days are different here. 0 to 3 days is acute, subacute, and then you have all the clinical criteria. I'm not really going to the depth because for want of time. And of course, the best way when you have the diagnostic criteria, when there is an increase, 50% increase in gradient, there's subtle increase in the cusp thickness more than 2 millimeters. Then of course, one is justified. If the surgery for patients with obstructive left-sided and there is a hemodynamic instability, or thrombolysis for high-risk surgical cancer. That's again where the role of thrombolytic therapy comes in. So I think you will hear more of thrombolytic therapy in this context because more and more patients are really going for a structural intervention these days. So to conclude, I would say, though rare, this is a very serious complication most often encountered with the mechanical procedure, and there's a significant mortality and morbidity. And thrombolysis has been increasingly used and as an alternative surgery, as a first-line therapy. But I think you should use your clinical judgment and all the available modalities of investigation at your command to decide on which form of therapy would suit the patient better. Thank you all for the kind attention.
Thank you, sir. I would now request our moderators for their closing remarks about this.
Maybe my good friend, Dr. Jaishankar, you should start.
Yeah, I think Dr. Jayagopal, as usual, has been succinct and very precise. For me, it was a good recollection of how we should handle the prosthetic valve thrombolysis without having to go through the article. Very nicely summed up, sir. And of course, we had good cases which all of us encounter at some stage in our clinical practice. And it's a good revision for me personally. That's all I can say.
Yeah, I also join Dr. Jaishankar in saying that it was a beautiful talk as usual, and it is nothing surprising because Dr. Jayagopal, whichever talk is assigned to him, he does justice to the talk. So he really goes into the depth of the subject and he presents every minute detail in a way only he can. So I really enjoyed his talk. Absolutely illustrative discussions, and the two cases also added to the whole thing. And Dr. Jayagopal, I was very happy to see that some of the very initial cases in the Indian experience way back in 1991, I'm sure it must be during his DM days in Jayadeva, those two cases. And we also had a lot of experience in Sri Chitra when I was a PG in 1995 there. So we have some of the centers dealing with this problem in large numbers. So we have a lot of experience. And as all of you rightly said, streptokinase used to be the only agent those days. And the surgeon will not accept the case. So we all had, whatever be the NIHA status, whatever be the thrombus burden, we go by clinical judgment, muffled heart sounds as what Dr. Jayagopal stressed, clinical value, pulmonary edema, muffled heart sound, high gradients, fluoroscopy, confirmation, streptokinase straight away, 1 lakh bolus followed by 1 lakh every year till the clicks appear. And a lot of times the clicks appear. Unfortunately, some patients can have stroke. That's the only sad part of that. And now the days and days, as Dr. Jayagopal said, we are going into ultra small doses given over a very protracted period of time. Very low dose, very long infusions, like 24 hours infusion. And even that MMC experience he told about some cases where it went beyond 40 hours. So very low dose and very long duration probably explains why the systemic embolism is lesser. Probably that's what I understand, because the lysis is so small, so slow and steady that large chunks of embolism probably don't happen. That's what probably appears to be theoretical wisdom behind that. I really enjoyed your talk, Dr. Jayagopal, as usual. Thank you very much.
Thank you for your comments.
Lovely cases. Yeah.
Dr. Guru and Dr. Kagita, would you like to share any thoughts? Now we come to the end of the program.
Thank you so much for giving me this opportunity.
Dr. Guru?
Maybe what would be the best modalities, I suppose, because MDCT, how possible, if it is okay, fine. At least, personally, I feel is definitely at least one transesophageal echo is a must before we start lysis. At least that gives the thrombus burden at least reasonable. If it is not a clot, at least you can think of the second possibility like PANAS, if there is no clots at all. And visitation, it most of the anatomy and pathology, it will reasonably differentiate. So before lysis, I feel transthoracic echo is a must.
Well, in a center where you have this availability of a transthoracic echo in your CCU, it's fine. But I think we all find it so challenging to bring our echo machine down to the CCU where the patient is sick and then to do a it's difficult. So I think, but by and large, I think our clinical decision based on the presentation and at least a bedside echo, I think it's fairly accurate. I mean, when you find an INR is subtherapeutic, I think in most of the cases I don't think there's a real worry about the diagnosis. These are all required only in selected cases. What do you feel, Dr. Jaishankar and Dr. Natarajan? What is your?
I think there's a small group of patients who have a thrombus on top of a PANAS. So you may not have complete resolution of gradient. That also we have seen when I was a student in GB Pant about 20 years ago. So that's what the consultants over there used to comment. That if the gradient doesn't come down despite thrombolysis for 48 hours or so, start thinking of PANAS. But nowadays, MDCT they have to distinguish. So that's one thing which I recollect now.
The other important thing is that even if the lytic therapy, when you administer it, the patient becomes better even by 6 hours. So the complete resolution might take a little longer.
Right.
But I think you can see the effect right in front of your eyes. It's like,
And the other catch is if you get complete resolution and the gradient come down rapidly down back to normal, better to stop the lytic therapy rather than waiting for the full 24 hours of. That's the value of serial echoes, so that you don't keep giving the lytic therapy.
Yeah, the only question is about when you use streptokinase, because we were all, the era of using heparin along with streptokinase long back. But then nowadays it's not recommended. So, but when you use a tenecteplase, at least the coronaries, we are fairly certain that you should keep the heparin going, right? So the only problem is this is an add-on. The worry if you use streptokinase, then when do you start this heparin? How do you keep it going? So whereas with tenecteplase, it's fairly clear. So these are some advantages of this molecule. And of course, I think it's finally a little bit of luck also. Luck favors the brave. So I think when you take a decision to lyse a patient, I think it's often, 18% thromboembolism is no joke. I think it's a worrying thing, right?
More stress to the physician.
Yes, absolutely. But how often do you think in your mechanical prosthetic valve thrombo, how often do you have to send them for surgery these days?
Surgery, quite a few. I've had 2 cases where I can recollect massive thromboembolism. Surgery, yes, a few cases I've sent, but most often I have ended up lysing the patients. Other reasons discussed.
With what Dr. Jaishankar says. Fortunately, some of these patients are not that very unstable. Though the algorithm says class 4 surgery, a lot of times they are class 2, class 3, fortunately. So, and the thrombus does not appear to be that very large. And to add to it, the decision becomes easy in centers where the surgeons are reluctant. So there is more of lytic experience than probably in countries in the West. There maybe there will be more surgery in preference to lytic therapy. In the Indian context, I still feel there will be more lytic rather than surgery, other than probably very sick patients with very large thrombus burden. I agree with you.
Streptokinase is much cheaper than a redo surgery, no doubt.
Streptokinase is out of the American guidelines because it is no longer available in the country in the first place. And more, even in the Indian context, streptokinase is taking the back seat in pulmonary embolism, in prosthetic valve thrombosis, as well as acute myocardial infarction. Acute myocardial infarction in Kerala, you should not use the word thrombolysis. because you may be murdered actually, because only primary angioplasty is being done. But I fully agree that alteplase also is a good agent, isn't it?
Yeah,
Very
it's a good agent. In fact, that was the first recommended agent, no?
25,
One of the first.
25 hours, 25 milligrams over 25 hours. So it appears reasonable that at the end of this discussion, not a very sick patient, not a very large thrombus burden, the way to go about is lytic therapy, and that too with agents like tenecteplase and alteplase, rather than the age-old streptokinase, which Dr. Jayagopal, me, and Dr. Jaishankar would have had experience during our very, very early days.
Well said. I think you have summed it up very well. So, Dr. Neha, I think we have crossed your 9:15.
No, sir, I am actually thinking that would one session be enough to discuss this topic, because there are, after your presentation, there's so many things which are getting unfolded, and this is such a niche topic and so many aspects being discussed. Probably we'll have to come back again with all the experts and discuss even more about this topic. So thank you so much, sir. Thank you so much for your presentation, for your talk, for enlightening us. And thank you so much, Dr. Guru and Dr. Kishan, for your wonderful case presentations that sparked a very niche, the very niche area, very specific topics. So that sparked a conversation. And as Dr. Natarajan said, Dr. Jaishankar sir, you rightly pointed out that when it comes to Indian settings, so the role of lytic therapy comes into place. So thank you so much for your time, sir. We are indeed thankful. Thank you, Dr. Jayagopal sir, for conceptualizing this. And each time we come back with a new concept, so that adds to the freshness of the program. So we promise we come back again next month with another exciting theme, another topic. Till then, all of you stay safe and stay healthy. And good night, everyone. So we will wrap up this program. Thank you so much for being with us.
Bye-bye. Bye.
Thank you all. Thank you, sir. Thank you, Dr. Neha.
Thank you very much.
Good night.